So good morning, everyone, and welcome to the September 2024 session of Journal Club. With regard to scheduling, we've had multiple inquiries as to why this is scheduled the third Friday instead of the fourth Friday of the month. And it all has to do with central resident conflicts. So if ever the Journal Club is a week early, it's due to conflicts with resident schedules. Next week, there's a Department of Medicine quality improvement curriculum that is mandatory. So that is the reason for the early date this month. Today, we welcome back Drs. Nitzan Segal, Geriatric Medicine Rehabilitation Fellow at UHN Sinai, and Mercedes Lupo, PGY5 co-lead resident in our training program, two prior presenters in this forum. Before we start, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. As a reminder, I will also provide a link to maps of Ontario treaties signed by Indigenous peoples before. It includes Treaty 13, also known as the Toronto Purchase, which was signed on August 1st, 1805 by representatives of the Crown and certain Mississauga peoples. This treaty covers approximately 250,000 acres, including the land here, Toronto, that many of us now call home. First, the short presentation from Dr. Segal, Cancer Rehabilitation Services for Older Women with Breast Cancer, Impact on Health-Related Quality of Life Outcomes. Nitzan, please go ahead. Thank you.
Thank you. I'll just share my slides.
Perfect.
Can you see?
Yeah, perfect.
Okay, sorry for that. Okay, so good morning, everyone. Today I will present a study from the Journal of American Geriatric Society that evaluates the role of rehabilitation services in improving the health-related quality of life in older women with breast cancer. I have no conflict of interest. Breast cancer is the most common cancer among women in the US, with 43% of diagnosed occurring in women aged 65 or older. Older women with breast cancer are vulnerable to acute, late, and lasting symptoms and decline in health-related quality of life due to coexisting cancer and cancer treatment, as well as other comorbidities. Addressing these issues is crucial to maintaining their independence and quality of life. For many women, decline in health-related quality of life begin even before their cancer diagnosis, and this decline tends to worsen over time, especially during medical treatment, hospitalization, and symptoms or disease progression. When asked, older women with breast cancer report that maintaining their independence and quality of life are highly valued treatment goals, but that these needs are rarely proactively addressed. Oncology clinical practice guidelines, including the latest guidelines from ASCO on the management of older adults receiving systemic therapy, recommended routine screening to identify decline in function and health-related quality of life. They also recommended referral to outpatient cancer rehabilitation services for those experiencing or at high risk for decline. However, fewer than 20% of survivors experiencing functional decline have access to or receive rehabilitation care. One significant barrier is poor understanding of how valuable outpatient physical and occupational therapy can be. Many patients may not realize how much cancer treatment will affect their quality of life, and even fewer know that physiotherapy and occupational therapy services are available to help address these issues. The primary aim of this study was to examine changes in health-related quality of life outcome for pre to post-rehabilitation. And the exploratory goals aim was to identify the specific impairment treated by the physical and occupational therapy, as well as the unique benefits for each services. This was a retrospective observational cohort pre to post study of EMR data from the National Outpatient Rehabilitation provided by Cancer Specialized Rehabilitation Services, and data were collected between January 2020 to October 2022. The study included older women, age 65 and above, diagnosed with breast cancer, who attended at least 3 sessions of physical or occupational therapy. Rehabilitation services were delivered by licensed therapists specialized in cancer care and provided across 565 community outpatient clinics in the US. Interventions were tailored based on each patient's needs and the type and frequency of therapy decided by the therapist assessment. Primary impairment treated by physiotherapy and occupational therapy included weakness or atrophy, pain, upper extremity impairment, lymphedema, fatigue, difficulty walking, scar tissue fibrosis, posture, neuropathy, or cognition. The primary outcome was the change in patients' health-related quality of life from pre to post-rehabilitation. And the study used the PROMISE patient-reported outcome measurement system, which developed and validated by the NIH to assess health-related quality of life outcome. This measure includes global physical health, global mental health, physical function, and ability to participate in social and activities. Each measurement scored using the T-score, and a score of 50 represents the US population average. Minimal important change, the MIC, was 2 points. Here you can just take a look at the questionnaire, the global physical health and the global mental health, and the questionnaire of the physical function short form and the ability to participate in social role. The statistical analysis for this study was conducted using the linear mixed effect model to examine change in health-related quality of life from pre to post-rehabilitation. The model accounts for important covariants such as age, US region, payer type, rehabilitation service type, the number of visits, and the duration of care. Also, estimation marginal means and the standard error calculated for each outcome. And additionally, interaction effect between time and service type and between time and age were examined. Table 1 represents the case characteristics of the study participant in overall and by service type, physiotherapy and occupational therapy. So the study included 694 participants with the average age of 71 plus minus 5 years. The majority of participants were white and most had federal funded insurance. Of the total cohort, 83% attended physical therapy, while 17% received occupational therapy services. Participants in occupational therapy had more visits with a median of 12 visits compared to 11 visits in the physical therapy cases. This table summarizes the improvement in health-related quality of life across 4 domains measured by the PROMISE. From initial evaluation here to discharge after rehabilitation, significant improvement were observed in all health-related quality of life outcomes, even after controlling for covariant with p-value lower than 0.001 for all outcomes, as you can see here. The results show significant improvement in the PROMISE T-score for global physical health increased by 3 points, as you can see from here to here. For physical function by 1.9, for ability to for global mental health 1.8, and for ability to participate in social role by 2.3. The improvement met the minimal important change threshold, that was 2 points, for both global physical health and ability to participate in social role and activities. Importantly, no significant change by time, interaction effect were founded, meaning that the age did not affect the effectiveness of rehabilitation services over time, as you can see here. In this retrospective observational cohort study, the researchers observed significant improvement in health-related quality of life among older women with breast cancer who participate in community-based cancer specialized outpatient physical and occupational therapy across the US. This finding allowed with previous systemic review showing that cancer rehabilitation improve health-related quality of life outcomes and support the call for ASCO and other organizations to routine screen and refer to rehabilitation services as part of standard of geriatric oncology care. This finding highlights the need for better access to rehab services and to support for improving healthcare policies. For the critical appraisal, I used the CASP tool. The study had clear objective, focusing on assessing the impact of physiotherapy and occupational therapy on health-related quality of life in older women with breast cancer. A natural third party identified case from the rehabilitation EMR using predefining criteria, minimizing the selection bias. The context and frequency of rehabilitation were individualized, potentially leading to variability in exposure and maybe performance bias, as not all participants received the same intensity of all therapy type. Health-related quality of life was measured using the PROMISE tool, which was developed by the NIH, and which is both valid and reliable assessment tool. The study controlled for some confounders, such as age, region, payer type. However, key potential confounders like frailty, baseline function, cognitive baseline, and disease stage were not reported, and maybe they could influence the rehabilitation outcome. The average duration of 11 sessions of PT and OT was sufficient to observe significant change in health-related quality of life. The results were accurate with small standard error, valued ranging from 0.31 to 0.35, and p-values below 0.001 indicate strong statistical significance. The results are credible and align with previous research showing that benefits from cancer rehabilitation. The results were partially applicable. The study intervention was conducted by cancer specialized PT and OT, which may not limit the relevance in area without access to specialized care. Additionally, the study population had mean age of 71, which may not fully represent the older adult population. This study support for routine cancer rehabilitation referrals and provide evidence to advocate for better access to rehabilitation services. So just to conclude, older breast cancer survivors are at high risk for experiencing ongoing symptoms and declining their health-related quality of life. The research we review provides strong evidence that using cancer rehabilitation services in older adults can significantly improve outcome. Importantly, this highlights the need for cancer rehabilitation to become a standard part of care in this population. And for our geriatric clinic, it's essential to refer older cancer survivors with symptoms or functional decline to rehabilitation services, as the evidence shows that it can significantly improve their quality of life and health outcome. Thank you.
Great. Thank you very much for a beautiful presentation, concisely and efficiently presented clearly. I'll open it up to the audience for questions. Barry has his hand up. Go ahead.
I echo that excellent presentation. I'm assuming from the way you presented that there's data that this is generalizable to other cancers, both in men and women. So I'm taking that for granted. I've been involved recently with a couple of cases where patients have the resources to get more intensive physiotherapy in the home, and did extraordinarily well because of that. Is there any literature on providing, and because the intensity of physiotherapy you get through our present home care is very, very limited. Is there any evidence for home-based physiotherapy in some of these cases?
So that's a great question because I think that the research did try to do real life research compared to other research in the past. And I think what you mentioned for your patient, what I assume they did at first some program for outpatient and then they continue at home, which improve the quality. I think there are some not very high quality research about home physiotherapy and occupational therapy, but as we know, the intensity is less than the special cancer program. And I think in this study, the physiotherapy and occupational therapy were licensed cancer treatment, which is very unique because this kind of very high quality research is not available in other area which are not center-based. But I do think it's good. I did wanted to present this study because it gives us good thoughts about how to progress in the future. And I think we should use whatever resource we have.
Great, thank you. Any other questions? Perhaps I can also ask, I share your statement or concern about the missing confounding variables that were not reported. If you look at the table 1, it's not very detailed. I don't know if there was more in the supplementary material, but I wonder if you can comment on where the individuals are in the trajectory of their illness and whether that impacts the efficacy of the intervention.
So thank you. It's a great question, and I agree. And there isn't no data on the disease stage. I do think that they did try to emphasize that it's important even for survivors. So I guess there are patients with chronic disease, but they didn't specify about the stage course. But I do think that it's important to take from this paper that even patient after recovery or survivor patient after few years, as they say in the background, can have symptoms because they did with scar tissue and lymphedema and so on. So that's why I think it was important to show this paper, because patient can have chronic symptoms and we can help them with the chronic symptoms, although they didn't specify that in table 1.
Thank you. Gary, go ahead.
Thanks very much, Nitzan. The clinical epidemiologist in me requires me to say that the methods used here are certainly what I guess we would generally consider more hypothesis generating. I think, I don't know if you want to express a bit, some of the limitations have already been discussed, but I just think we need to be a bit cautious, even though intuitively as geriatricians, we believe this to be the truth or the case. I would suggest that the level of evidence from this observational study is more hypothesis generating and would require further study. So I apologize, but the clinical epidemiologist in me requires that statement.
I can say I agree, but there are not very high quality resource in this specific cancer rehabilitation for older adults. So I did wanted to show this study to show the importance of the topic, and I agree.
It wasn't meant to be critical. It just want to make sure that we all recognize that, without a control group, without any degree of randomization to account for issues of bias, that we need to, I guess, interpret the results in the context of the methods that are used.
Great. I don't know, do we have any of our allied health professionals? Is there a physio or an occupational therapist online? That may, if not, for the interest of time, Nitzan, thank you again for a great, efficient, and clearly presented summary of this paper. And we'll move on to our second presentation. If there are any other comments or questions for Nitzan, I welcome the audience to include them in the chat box. And our second presentation comes from Dr. Mercedes Lupo, again, our co-lead resident to present on Suvorexant for reduction of delirium in older adults after hospitalization. Mercedes, please go ahead.
Okay, so you can see my slides, okay?
Yep, and hear you well. Thank you.
Okay. Thank you. So yes, the topic is on Suvorexant for reduction of delirium in older adults after hospitalization. And I have no conflicts of interest to declare. We'll review some of the background literature in this area. I'll introduce the study itself. We'll run through a critical appraisal and then come up with some bottom lines. So I don't need to remind us all how common delirium is in hospital, as it's something that our field manages on a near daily basis. But to set the stage for why we're continuously looking for ways to prevent and manage it, I'll review that delirium leads not only to immediate management issues and healthcare costs, but very important outcomes for patients and families, such as long-lasting cognitive impairment, functional decline, reduced likelihood of returning to one's own home, and mortality. And so we turn to what we know to be helpful for prevention of delirium. Again, I recognize I'm preaching to the choir when I bring up the importance of non-pharmacological measures for delirium prevention. I've included two more recent works, a systematic review in Age and Aging in 2015 and a Cochrane systematic review in 2021, which highlight overall there to be a reduced risk of incident delirium with implementation of non-pharmacological measures, things we know and love, such as reorientation, sleep hygiene, attention to hydration and nutrition. While Martinez's group noted a small reduction in delirium duration, Burton's group noted a non-significant reduction in delirium duration. And then this was similar for hospital stay and mortality. And so these are the kinds of things we're always sure to reinforce when we are seeing patients with delirium and working with their care partners. And so what about antipsychotics? Though we recognize the role for antipsychotics in management of delirium for safety reasons and when delirium is distressing to patients, what about their use in actually preventing delirium? So the evidence has not been very conclusive, and we have a systematic review and meta-analysis from 2016 from Dr. Inouye and her group that showed that antipsychotic use is not associated with change in delirium incidence, duration, severity, or length of stay, with a lot of heterogeneity among the studies. They also did not find any association with mortality and overall felt that the evidence does not support the use of antipsychotics for prevention of delirium. Melatonin has been proposed and trialed as well. The thought behind this is to act on the sleep-wake cycle, which we'll review a little bit more when we talk about Suvorexant. Melatonin, as we know, regulates the circadian rhythm, and this decreases with age. So hospitalized older adults are more vulnerable to circadian-related sleep-wake disturbances and therefore potentially delirium. As well, previous studies have indicated that melatonin receptor agonists have anti-inflammatory properties, which may be particularly relevant given that inflammatory responses are implicated in the pathogenesis of delirium. So several studies have reviewed melatonin's use. However, again, there's a high degree of heterogeneity in studies and in delirium itself. So multiple RCTs have shown inconsistent results over time. In 2010, an RCT showed that melatonin reduced delirium in hip fracture patients, where in 2011, an RCT by Al-Ama's group suggested it may prevent delirium with less confidence. In 2014, an RCT showed melatonin did not prevent delirium in patients admitted to general medicine. And in 2021, we have a meta-analysis showing melatonin could prevent delirium in surgical and ICU patients, but not in medicine patients. In a 2023 meta-analysis of melatonin receptor agonists, MRAs, suggested benefit in preventing delirium, but there was overall low certainty of evidence. This brings us to another component of the sleep-wake cycle, orexin, because we understand that sleep-wake disturbance is a common clinical feature and contributing factor for delirium. So orexin is a neuropeptide that is produced in the hypothalamus that helps to regulate the sleep-wake cycle. In contrast to melatonin, it's released during wakefulness and increases the activity of brain regions that promote wakefulness. This is just a visual schematic showing how orexin interacts with various neurotransmitters to maintain arousal, so including acetylcholine, serotonin, noradrenaline. Orexin has been found to be increased in the CSF of individuals with moderate to severe Alzheimer's disease compared to mild Alzheimer's, and it's also associated with inflammation or inflammatory states. So found to be, for example, higher in the brains of rats with acute pancreatitis. And considering that more advanced dementia and inflammatory states are risk factors for delirium, it's hypothesized that there may be increased orexin and therefore wakefulness in delirium. And so the thought is that the use of orexin antagonists may help to reduce sleep-wake cycle disturbances and prevent delirium. Which leads us to the agent Suvorexant, which is an orexin receptor antagonist, and that it works to prevent the induction of wakefulness. So it's approved in Canada under the name Belsomra. Its onset of action is about 30 minutes, which is a feasible timeline. Its half-life is about 12 hours and generally recommended to take about 7 hours at least before they plan to be awake. Its metabolism is mostly hepatic, and therefore, while there are no adjustments needed for renal impairment or suggested for renal impairment, it's not recommended in severe liver impairment as it hasn't been studied. Dosing recommendations start at 10 milligrams for insomnia in adults, and the maximum recommended dose in Canada is 20 milligrams. If it's used with another CYP3A inhibitor, it should not exceed 10 milligrams. The main contraindication is narcolepsy, and some warning signs that come with it are that it can cause abnormal thinking and behavior, CNS depression, complex sleep behaviors, REM sleep effects, and worsening depression. Studies that have looked at Suvorexant so far have been mostly observational or small RCTs, which have shown some support for the use of Suvorexant for delirium prevention. A 2020 meta-analysis demonstrated that Suvorexant was associated with a lower incidence of delirium and longer time to delirium, though again, most of the studies had smaller sample sizes. So this is a summary of many of the papers looking at Suvorexant to date. So just to highlight some of the sample sizes. And that what you'll see here and on the next slide is that often, or in some of the studies, they used combinations. So for example, we see Ramiltoin, which is a melatonin receptor agonist, and or Suvorexant. Again, we see use of Ramiltoin and Suvorexant in the second one highlighted there, and then Suvorexant and Lemborexant, which is another orexin antagonist. But this one has a longer half-life, and I haven't seen as much literature around it in delirium prevention. Which brings us to the paper I wanted to discuss today. So this RCT was published in JAMA Open Network in August of 2024. The population of interest included adults aged 65 to 90 hospitalized in Japan for acute illness or elective surgery who are at high risk of delirium. The intervention included 15 milligrams of Suvorexant, which we recall is an approved dose in Canada for insomnia, and administered before bed each night for 5 to 7 days post-admission, or a visually matching placebo tablet. The primary outcome that they looked at was the proportion of participants who developed delirium during their assessment period using the DSM-5 criteria for delirium. Looking at things a little more closely, these adults were hospitalized and at high risk of delirium. And so hospitalization was either for acute disease or elective surgery planned 2 days after admission. Acute disease included infections, cerebral disorders, cardiac disorders, respiratory disease, injuries, or neoplasms. And so many of the things we'll see on the inpatient medicine units. These patients were quite sick, so they had a severe disease state measured by an Apache 2 score of 8 to 30, which is associated with anywhere from 8 to 55% risk of non-operative death. Or they had a decreased daily living function of an ECOG 3 to 4, which represents a disease state limiting one's ability to perform self-care, and often remaining in bed for more than 50% of their day, or both of those criteria at screening. And then high risk of delirium in both groups was represented by MCI or mild dementia using the Nishimura Mental State Scale for the elderly, or a history of delirium in any prior hospitalization, or both. Those patients who were excluded were those who had developed delirium during the screening period based off DSM-5 criteria or the delirium rating scale. If they were currently using psychotropic drugs, if there was history of drug or alcohol excess use, if they had excessively severe disease 2 weeks before admission. So that, if you recall, the severe physical disease was an Apache 2 score up to 30, and greater than that was excessively severe, so those were excluded. A history of epilepsy or Parkinson's. And then I'll highlight that they excluded individuals with moderate to severe dementia, remembering that it was in this population more so where they found orexin to be much higher. So I thought that was interesting to note. The trial was conducted at 50 hospitals in Japan between October 2020 and December of 2022. It was double-blinded, and participants were randomized to Suvorexant or a visually matching placebo, stratified by their reason for hospitalization, so either acute disease or elective surgery, and by their age, so essentially above or below age 75. And the trial consisted of a screening period, assessment period, and a follow-up period. So screening was done either 14 days before admission for surgery or within 24 hours of admission for acute disease. Assessment then ran for 8 days from the first dose of the trial medication. On the day of randomization, a qualified rater used the DSM-5 or the Delirium Rating Scale scores. If this was done more than 3 hours before they were scheduled for their first dose of medication, they repeated the assessments to make sure they had not developed delirium before they received their first dose. And then those who were assessed to have delirium between randomization and the first dose were not given the trial medication, but in actuality, this didn't occur in the study. During the assessment period, the DSM-5 and delirium rating scale were repeated on a daily basis in the mornings. And if delirium was noted outside of those daily time points, the rater then repeated assessments. And if they developed delirium, the medication was then discontinued. During the assessment period, the investigator also assessed for the need for non-pharmacological measures for delirium and implementing nursing plans for that, as well as the use of hypnotics other than the trial medication during the assessment period. And if for some reason a hypnotic was needed, then the trial medication was stopped. Follow-up was for 14 days after the last dose. And I wanted to highlight that I don't know what specifics of non-pharmacological measures were necessarily provided to each patient, but we're led to assume that everyone was sort of optimized from this perspective. We've mentioned already some of the assessment tools they used during the assessment period. So the DSM-5 is a well-known set of criteria for delirium. The DRS R98 stands for Delirium Rating Scale Revised 98, and it's a 13-item scale for delirium symptom severity. It's found to have high inter-rater reliability and internal consistency. It's also identified, they also identified the delirium subtype as hyperactive, hypoactive, or mixed, and the etiology. And then the Richards-Campbell Sleep Questionnaire is a 5-item visual analog scale found to be reliable and valid with a good degree of concordance with sleep efficiency index of polysomnography. They had one main primary efficacy endpoint and multiple secondary endpoints. So the primary efficacy endpoint was the proportion of participants with delirium during the assessment period using the DSM-5. The secondary endpoints were firstly delirium severity, and that was based on the DRS, and then the proportion of participants with delirium during the assessment period characterized by a cutoff score on the DRS of equal to or greater than 14.5. And then they looked at safety indicators, looking at adverse effects, labs, and vitals through the assessment period. And they had a set of predefined events of clinical interest, recognizing some of the warnings that we talked about with use of Suvorexant. So cataplexy, suicidal ideation, complex sleep-related behaviors, for example. The investigators planned for 200 randomized participants to have 90% power to demonstrate superiority of Suvorexant to placebo using a two-sided alpha of 0.05 and a true treatment difference of about 18%, from a 30% risk in the placebo group to 12% in the treatment group. And this is based on prior research that showed that delirium is seen in about 10 to 20% of older adults hospitalized for surgery or internal diseases. But they increased that 10 to 20% to 30% because they postulated that this population was higher risk of delirium. And then previous studies found a treatment difference of around 18% points versus control. So a similar difference was used for this trial. Participant characteristics were fairly similar across the treatment groups. Most of the participants were a couple of things that I highlighted, not necessarily differences between the groups, but in the all of the trial participants as a whole. So most were age 75 and above. Most were admitted for elective surgery at 62.6%. And most had borderline or mild dementia. And though they didn't outline whether there were differences in surgery subtype by group, as in Suvorexant or placebo, they do outline in the text the breakdown of elective surgery types, with the majority being bone or joint or nervous system, skull and spine at 53.5%. So just sort of highlighting that like recognizing the risk, the high risk of delirium with neurosurgery, for example. I would have liked to maybe see if there was any difference between the two groups based on surgery subtype. 23 participants in the Suvorexant group discontinued treatment and 31 in the placebo, and that was mainly driven by development of delirium. Otherwise, it appeared to be a fairly feasible intervention that a small number of patients withdrew or otherwise had adverse events. This is a summary of the efficacy of the trial. So with respect to the primary efficacy outcome of development of delirium, as assessed by the DSM-5, we can see that more patients in the placebo group ended up developing delirium, 26.5% compared to 16.8%. However, the treatment difference was not significant looking at confidence intervals and p-value. And when they looked at things then based on delirium subtype, they found that those who took Suvorexant were less likely to develop delirium of a hyperactive or a mixed component, but that actually more patients in the Suvorexant group developed hypoactive delirium. And then when doing their post-hoc analysis, the hyperactive plus mixed subtypes were found to have a statistically significant reduction in delirium by about 10% if taking Suvorexant. With respect to secondary endpoints, those in the placebo group developed more severe delirium as assessed by the DRS, but this was not significant, and the proportion of patients who developed delirium according to the DRS was more in the placebo group, again, not significant. When they broke down the results for hypoactive delirium specifically further, they found that things differed between those who were hospitalized for acute disease versus elective surgery. So in those with acute disease, Suvorexant actually directionally reduced hypoactive delirium. But in those admitted for elective surgery, Suvorexant directionally increased hypoactive delirium. And they present a Kaplan-Meier plot of time to delirium, and a greater percentage of people in the placebo group developed delirium earlier compared to Suvorexant. And the event rate per 100 person days was 1.6 in the Suvorexant group and 3.3 in the placebo group, but not statistically significant. They continued to assess safety for 14 days after the last dose. They found similar effects between groups, except for more delirium in the placebo group, as we know, and one death in the Suvorexant group. However, the death was due to urosepsis, and the investigators deemed this not to be drug-related. When looking at those pre-specified events of clinical interest, they found that these were generally low and similar between groups. However, they did note that falls, hallucinations of the hypnagogic, hypnopompic type, and somnolence were seen more in the Suvorexant group. And so here is the breakdown of that. I do highlight as well that falls were notably more present in the Suvorexant group at 7% compared to nearly 3% of those in the placebo group, which is an important, I think, adverse effect to keep in mind in our population who's often at increased risk of falls. So the authors discussed their thoughts on why their results were not as supportive as maybe some prior studies. The first thing they highlighted was that the prior studies did not always distinguish between subtypes of delirium. So one of the prior studies actually noted that they excluded hypoactive delirium because it was felt to be less important in immediate post-operative management than other subtypes. And the relevance of this is that perhaps the other studies focused on hyperactive or mixed and overlooked the potential effects of hypoactive delirium. Remembering that in this study, there was an increase actually in the hypoactive delirium, but a statistically significant post-hoc benefit for hyperactive or mixed. They noted some interesting findings that came from their study in that the lack of benefit for Suvorexant on hypoactive delirium was mostly driven by those hospitalized for elective surgery. And if you recall from the baseline characteristics, that was actually the majority of patients. The onset of all these cases were in the morning, typically 1 to 2 days after surgery. So they wondered whether this was a combination of sustained somnolence from the previous night's Suvorexant, recalling that the half-life is about 12 hours, and residual effects of the anesthetic or sedatives used for surgery, or even just the weakened condition of patients after surgery. They also postulated that the percentage of people who developed delirium in the placebo group was actually lower than what was originally planned in the trial design. So they thought that this would be about 30%, like we mentioned earlier, based on prior studies and the fact that this was thought to be a higher risk of delirium group. However, the percentage was less than that at 26.5%. So the potential treatment effect may have been reduced as a result. And they wondered whether some elements of the trial design, like ensuring participants were not taking psychoactives and implementing non-pharmacological measures, may have impacted the overall risk of delirium, which were not elements seen in all prior studies. Coming now to the risk of bias assessed with the Cochrane Risk of Bias 2 tool, I felt overall the risk of bias was low, and that's based off the next set of slides. So selection bias I felt to be low given the allocation sequence was random using a computer-generated assignment, and this was concealed to participants. Overall baseline characteristics were fairly similar between groups, though I did highlight that there were more patients with mild dementia in the Suvorexant group than the placebo group. However, I would expect that these patients to be at higher risk of delirium and therefore produce sort of the opposite of what was mostly found. So I don't know how much that was a flag. And with respect to performance bias, I felt there to be overall low risk again, as participants, investigators, and other personnel involved in administering the intervention and the evaluation of patients were unaware of assigned intervention. They used a modified intention to treat analysis to estimate the effect of assignment to intervention, which was appropriate as it maintains the benefit of randomization. Data was available for nearly all randomized participants, leaving a low risk of bias for missing data. And then there was low risk of measurement bias because the method of measuring the outcome was appropriate. They used validated tools, and those administering the tools were trained and certified in their use, and they were unaware of intervention assignment. However, I gave a partial no to the second question because though the individual actually conducting the DSM-5 was trained, this was done at a cross-sectional time point and took data from the preceding 24 hours from medical records, the participant themselves, family members, and site staff, which could have introduced some variability. But overall, this still led to a low risk of bias. And then finally, in looking at publication bias, the data was analyzed according to their pre-specified analysis plan, and the numerical result itself was not selected on the basis of results from multiple eligible outcomes or analyses. With respect to external validity, there are limitations in generalizability, technically in that this was conducted exclusively in hospitals in Japan, and most participants had MCI or mild dementia, which may not always be reflective of our population. As well, those with moderate, as we talked about, individuals with moderate to severe Alzheimer's dementia were found to have higher orexin levels. So maybe there would have been a different benefit in those patients. And additionally, most were present for elective surgery as opposed to acute disease. I think that the strengths were the feasibility and the ability for participants to generally adhere, and with the exception of developing delirium, there was little dropout. Overall, we can say that though fewer participants developed delirium in the Suvorexant group compared to placebo, the result was not statistically significant. We can see that it at least did not cause more delirium than placebo overall. And the study showed some interesting results based on delirium subtype. Overall, it had a low risk of bias and was a fairly feasible intervention. In the future, I think the medication needs to be further explored for delirium, increasing the generalizability of results. I think it would be helpful to gain more confirmatory findings by delirium subtype and have a bit more information even as well with respect to surgery subtype. These are my references here. So thank you. I welcome questions and comments.
Thank you very much, Mercedes. Also beautifully presented and very clearly articulated with a great presentation materials also. Can I open it to the audience for questions or comments? I can add, I have a little bit of feedback from pharmacy. If the pharmacist is unable to unmute, I can share that Health Canada did approve this drug, but the drug company decided not to proceed to market it in Canada. And the rationale or the reasoning that I was provided was that at higher doses, the adverse effect profile was not deemed acceptable, and only the lower doses were approved by Health Canada. And so that's some comments from pharmacy. I see some hands going up. I would ask Mercedes, before we get to the first hand, do you have any knowledge of the funding source in this study?
I'd have to look back at that actually. Good question.
Okay, and go ahead, Gary.
Thanks, beautiful presentation, Mercedes. I think this is a good example of when you have, quotes, a negative trial, establishing, is this a definitive negative trial or not? So this is a very good example of a non-definitive negative trial with very wide confidence intervals that certainly could include significant benefit. As is true of most research, it's incremental, so we don't have a final answer. And I certainly perked my ears to the side effects and that increased risk of falls. And that, coupled with Dove's statement from the pharmacy about the higher doses, certainly wonder whether this will ever really see the light of day in a significant fashion. But interesting always to have new mechanisms of action for sleep and for prevention of delirium. So great job presenting. Thanks.
Thank you.
Thank you. And Gary, I wonder if we can ask for your comments too on this was a randomized study, but the sample size is quite small. And so whether or not the differences in the two groups and the baseline characteristics may account.
Yeah, and it's a common problem, and as a master in negative trials with small sample sizes, we often fall short of our intended sample sizes, and I think people forget, because it's a randomized trial, so they think de facto that means that you end up with groups that are equivalent to each other, but the facts are that with randomized trials, it's true if you get large enough sample sizes that almost de facto you'll have. So some of the cardiac trials that have thousands of participants, you'll see that the groups are almost virtually identical. But unfortunately, many of the geriatric type trials, you'll often see sample sizes of 100 per group or even smaller, sometimes 50 per group. And in those instances, randomization will not de facto work. And that's why it becomes so important to make sure all of the important variables at baseline are looked into at baseline, because it's very often you will end up with groups that are not equal. And then, of course, statisticians are wonderful, and you'll use statistical approaches to try to adjust for those differences. But, Dov, as you've heard me say many times, if at baseline the groups are so different from each other, using statistics to make them similar isn't effective. I mean, you have to accept that, unfortunately, the randomization failed because of small sample sizes, and these are not equal groups, and you can't really accept the results for what they are. So it's a big challenge, really, in geriatrics with having studies with small sample sizes and leading to non-definitive results, which is frustrating for the people doing the trial and for us, the readers and consumers of the trials.
Thank you. Mercedes, I scrolled down to the bottom of the paper, and the study was entirely funded by Merck. And the author declaration too, they all report receiving funding from the pharmaceutical company. And lastly, I do want to credit, it was Chris Van Lund. He does not have a microphone, but it was Chris Van Lund. Thank you for being a part of the forum and adding your comments to me as the pharmacy input. So with that, we're a few minutes, unless anybody has any final comments or questions. If not, a few minutes before the hour, the Journal Club evaluation link should have been sent to your inbox already. Great job presenting.